minus 40 to the.
Let's begin neuro. It's interesting as well as coding thing. So basically, spinal cord injury, which is our first lecture for the neurological point of view. How you gonna prepare for your neuro? That is something different from your cardio, pulmonary, other system what we have discussed. In the neuro, mostly like almost all the conditions they have UMN, LMN, nerves, so like polyneuropathy, they are like common symptoms. Like, it's not like that spasticity is different in multiple sclerosis and different in the stroke and different in the spinal cord injury. Spasticity means spasticity. It's not something like new symptoms. So once you are dealing with the question of spasticity, your assessment, your treatment is based on that real concept. So that is known as the neuro. If patient has a flaccidity. So now quad iguana syndrome or the GBS, flaccidity means flaccidity. So we have to assess, we have to treat, precautions, everything remains same. So what your question is and how you're gonna deal with this question is your basic for the neuro. If broadly I'm divided neuro into the three category. First is condition itself. So whatever your condition is, then the examination, then the intervention. Intervention is the core portion of your neuro, and after that, ethics. So now here ethics, this is a domain for the neuro. In that one, your questions related orthosis because neuro highly associated with orthosis. Your question related to the OT, SLP, swallowing problem. Sorry. Your question related to the social worker. Your patient's question related to the sexual life. Prognosis. These all are the like related questions that you come across with the neurological condition. So this is broadly okay. Now that broad application you can apply for the stroke patient. Broad application you can apply for your GBS patient as well as the spinal cord injury patient. Clear? So that way you have to move on. Now this is your background. Now related to the spinal cord injury. When you open a book, Sullivan, we are only referring one book, Sullivan. Once you are done with the Sullivan, my PPTs are really nice, which is a concise version of the Sullivan. So I prefer go through my PPT once, then open a book for intervention. Another thing is you have to go in the partition for the spinal cord injury. So what is overall you have to require for the spinal cord injuries? First, this is an injury. It is not like some pathological condition. So it is a trauma outside. So now once injury happen, your scenario comes first to identify the level, which is known as a neurological level. Then complete and incomplete injury. So complete and incomplete injury, here your anterior cord syndrome, central cord syndrome, posterior cord syndrome, cauda equina, conus medullaris, plus ACR level A, B, C, D scale that all count, right? Just a minute. So this is your first thing. Now symptoms. In terms of symptoms, patient has spinal shock, autonomic dysreflexia. Patient has, according to the level, their injury level, involvement of the bladder bowel, balance, gait. So these are the symptoms. Patient has dependency on the transfers of bed mobility, respiratory, as well as secondary symptoms, which is main DVT, heteropic ossification, tightness, contracture. So these are the main symptoms. So you are aware about their symptoms according to the level. Now intervention. Intervention, if you open a book, it is divided into the two portions. One is the acute, another one is the active. Now acute again divided into the two portions, examination, second is intervention. Same way active again examination and second intervention. So this is your overall going with the book. So I prefer you guys, go with the level wise. First is the in the compartment wise. So first is the spinal cord injury and this knowledge. Second is this portion. Third is acute portion. And the fourth is active portion. Clear? Okay, I forgot one more thing, and that is wheelchair. So wheelchair is a separate topic actually, but spinal cord injury highly associated with the wheelchair. Neurological scenario highly associated with the wheelchair. Wheelchair is given very nicely in spinal cord injury. I prefer go with my lecture first, then read the wheelchair, and also only wheelchair you can get from the therapy aid. Now what to do in the wheelchair? Okay, so let's go with the wheelchair first. In the wheelchair, first thing is according to the level, type of the wheelchair. Second thing, activity that patient can perform maximum according to the level wise in the wheelchair. Third, wheelchair mobility. Remember my words. What first word is activity? So the first word is activities. Right now I'm in the chair. I can reach out. I can move forward. I can bend. That is my activity. But if I'm going forward, that is my mobility. So wheelchair mobility, that word means patient is moving forward, backward, turning one side, turning other side, or wheelie. Now wheelie is something new word. Sorry. Wheelie is something new word, but means you are lean, like when you are pop up the front wheel of the wheelchair. That is known as wheelie. So this is your wheelchair stuff. And here you have to train the patient on the level surface. Level means ground level. Then on the curb means when you are walking on the footpath, the side portion which is little bit elevated, this is known as curb. Ramp, ramp means inclination. So if you see that, in the TTC bus and all, there is a ramp, inclination is there on many areas. They have an inclination for the wheelchair accessibility. So that is known as ramp, inclination. So this is main activity over that. Now, variety of the wheelchair. Just a minute, huh? Variety of the wheelchair means manual versus power, rigid versus folding. So this is the variety of the wheelchair. Plus wheelchair parts. So I have, I think, lecture of wheelchair or I have a PPT of wheelchair assistive device. If you are not getting, let me know. But wheelchair parts. So here the seat measurement, then the back of the wheelchair, then the wheels, then the foot angle. So this is all wheelchair part you have to go through in the wheelchair portion. So this is your wheelchair and spinal cord injury, and wheelchair and overall neurological patients is almost the same. Difference is according to the level, you have to select variety of the wheelchair. For example, C1, C2, C3, C4. Over here, patient cannot do anything. I need to go with the power wheelchair. Versus T2 standard wheelchair. So depending on the level, our selection of the wheelchair is different. But wheelchair management, because you are starting with the neuro, right away you digging yourself with the thoroughly through the wheelchair. Any question? Any question to understand about how to go and how to read the spinal cord injury? No question? Let's go move forward. So now spinal cord injury tracks ascending and descending track, which is a very basic. But again, don't dig yourself that, okay, what are the starting process of a descending track from the brain portion to the level of spinal cord, or what are the ascending track from the spinal cord area, where they are originating, what neurons they are occupying, and what relay center they are going in the brain. Very depth knowledge I can explain, but that one for PC purpose, it's very narrow. So I want that name of the track, function of the track. More than enough. Okay, all these things we discuss. Move on. Spinal cord. Spinal cord means what? So spinal cord is a central nervous system. Now nervous system is divided into the two portion, peripheral nervous system and the central nervous system. Central nervous system include brain, cerebellum, and the continuation of the brain in form of spinal cord. In the easiest way, our body is the school where the students, then the teachers, over there the principal, like vice principal and the principal. Students, what they are functioning, that is the muscle. The students is controlled by the teacher ideally. Nowadays it's not there, but ideally. So this teacher is your spinal cord lower level wise, like alpha motor neuron. And spinal cord receives signal from brain. So the brain actually considered as a principal. So this is our normal functioning of the body. That muscles which getting the signal from the spinal cord, and spinal cord getting the signal from the brain, as well as brain gives a signal, as well as spinal cord inform the brain about the situation. regarding muscles, regarding the environment, regarding the surrounding atmosphere. So overall counts, and then we are getting the signal. So this is the, for the neuro, you are working with this principle. But now for the brain, different area like basal ganglia, if there is a mechanical problem leading to the Parkinson, cerebellum, mechanical problem leading to the ataxia, in the brain, chemical problems leading to the traumatic brain injury, brain blood problem leading to this stroke, even brain meninges problem, meningitis, encephalitis, brain vestibular area problem leading to the vestibular disorders. So this is all regarding the your principal. How good principal? According to that, school is good. If the principal is inappropriate, school is inappropriate. That is the basic story for the neuro. Very basic. After that, how the information is conveyed to the spinal cord and how the spinal cord convey the information to the brain. So that is role of teachers. Track is problem, corticospinal tract is problem leading to the brain gives proper signal, but the tract does not deliver signal to the spinal cord. Or teachers are good, but the pune is not proper, ascending track is not proper. Again, information does not received by the brain does not give the signal. So the order is not passed. So that is your problem at spinal cord level. Don't remember principal, teacher and students. Remember the brain portion. Okay. Now onwards, we are working with the muscles. So muscles are the performer. But on the same time, muscle spindle, Golgi tendons, that gives a signal, sensory signal about the joint position, length of the muscles, proprioception, temperature, hot, cold through the skin. So muscle is not only the portion, muscle, skin, fat, the proprioceptors, all the receptors are activated, giving signal to the spinal cord. Again, spinal cord gives signal to the brain. So this is our normal function of the neurological system of the body. In the neurological system, if I'm going to say that this is my biceps, and on the same time I have a triceps. So in the body, always remember we are working with the two muscles. It's not only biceps that bending the elbow, it is also the triceps which lengthen, allow the elbow bending. So agonist and antagonist. Now remember what is known as agonist, Urvi Patel.
Yes, ma'am.
What is known as agonist?
So agonist muscle helps to make a contraction like a flexion.
Correct. So agonist contract. This is my biceps. If biceps contract, it leading to the elbow flexion. But agonist, for example, only biceps contract, sudden bend. And if my triceps, imagine my triceps is not allowing me to lengthen. So my triceps is tight. And even though my biceps is normal, but my triceps does not allow me to bend. Clear that thing? So that is known as antagonist muscles. And brain gives a signal to the agonist to contract and to the antagonist to the relax. That's why we are getting specific direction movement along with accuracy of speed, accuracy of the movement, accuracy of the coordination. It's not like I want to touch my head. It's not like first I'm going to bend my wrist, then elbow, then shoulder. It's not effective movement. But on the same time, if I'm going to elevate the shoulder, then bend, then little bit flexion, I can touch my head. That is known as coordination. Very coordinating way you gonna perform the movement. So this is all concept applicable to the neurological scenario. Any question? Any difficulty that you feel like, okay, I didn't get the the stuff and all? Everything is good? Perfect. So this is your basic thing that you are working with. Now remember one more thing. What I told you, agonist and antagonist. Payal Kansara, what is agonist? Payal, are you there? Let's go with the Drashti Panchal. What is agonist?
Ma'am, the muscle which is contract.
That is agonist. Now, for the neurological point of view, you have to also remember that muscles which is tight, it is known as antagonist. Now again, here it's little bit different terminology. So normal terminology and PNF terminology, because you come across with this type of variety in your neuro section. So the normal terminology means muscle which contract, it is known as agonist. Am I right? And muscles which is opposite to the agonist or relax, that is known as antagonist. On the opposite side, PNF, proprioception neuromuscular facilitation, that is the intervention technique. Remember, it is not the performance technique. So I am bending my elbow, this is my action, but I am working to improve my elbow flexion or to improve my elbow extension, that is my PNF. Here in the PNF intervention, the muscle which is tight is known as antagonist. Muscles which is tight or spastic, and muscles opposite to the antagonist known as agonist. So now, easy way, again biceps. In the normal function, biceps is my agonist and triceps is my antagonist. Everyone clear? But when I'm gonna communicate or I'm gonna discuss PNF technique for the neurological patients where biceps is spastic or biceps is tight. So now these biceps, spastic muscles, it is considered as antagonist. Tight muscles in the PNF terminology is antagonist. In the real, no. And opposite to the biceps, triceps is considered as the agonist. And that's why we have a technique, hold and relax, contract and relax, which is applicable to the antagonist, tight muscles. And another technique is hold and relax, agonist contraction, which is the triceps contraction. Clear now? We will discuss PNF, but that is the basic scenario. Keep in your mind that normal terminology, moving muscle is agonist, opposite is antagonist. PNF terminology, tight muscles is antagonist, opposite to the tight agonist, or spastic. Spastic is antagonist, opposite to the spasticity is agonist. Move back to the spinal cord again. So now spinal cord, basic portion. So it is start from the foramen of magnum. So this is also variety. Neuro is interesting. Skull. Now the opening of the skull from where the spinal cord is start to continuation. So this is known as the foramen of magnum, through which the spinal cord is begin, and L1 L2 means lower end of L1, upper border of L2. And below that, there is the ponytail, cauda equina, which is purely LMN. And now what is UMN and LMN? Let's discuss this thing in detail. UMN, upper motor neuron. LMN, lower motor neuron. Now any level, so if I am doing cross section of the spinal cord here, and I am getting the spinal cord variety. Here, alpha motor neuron, gamma motor neurons, these are the admin stuff because I told you spinal cord is a school, teachers. So here the admin stuffs are there where they receive, and here there is a dorsal ganglion, which is the kinematic chain, sympathetic chain, sorry, not kinematic, my wrong word. Sympathetic chain. Sympathetic means you might have angry so many times, particularly in front of the mom. It's easy to anger. So when you are anger, you are like fight or flight with your loved ones. That is your exaggerated sympathetic response. On the opposite, controller of the sympathetic is parasympathetic. Balance, we have a normal reaction. We are cool down, we are talking easily, we can control our temper. That is all sympathetic and parasympathetic, which is the autonomic nervous system. This is again the variety, beauty of the creators, that this autonomic nervous system control our visceras, our emotions. The autonomic nervous system control the blood pressures, heart, lung, all the visceras, bladder and bowels. So this is autonomic nervous system. Here, autonomic nervous system runs the sympathetic ganglion, the chain which is in the thoracic level. So these are known as dorsal root ganglions. So if you are, just a minute, if I have a spinal cord injury, so this is a cross section of the spinal cord where inside means gray matter, alpha motor, gamma, as well as the dorsal root, that is a dorsal root ganglion. Now this dorsal root ganglion, whatever, if I have touched the cold thing, if my cold sensation going to the dorsal root signal communicate with the alpha motor at the admin level, spinal cord level, they also communicate. So they also give signal to the outsiders, which carry the information to the principal brain. After analysis everything, if the circumstance is too fast, like I am, my hand is on the too hot surface, immediately I pick the hand. That is at the spinal cord level. But if something required to analyze and perform, brain activate. So that way the system works in our body. So this is my overall central thing. UMN, upper motor neuron. Now upper motor neuron means neurons which is outside the spinal cord. So basically alpha motor neuron, again I'm gonna say. So this is just example I give you. But alpha motor neuron which is inside the spinal cord, it is known as LMN. And that's why poliomyelitis, which attack on the alpha neuron, particularly at the lumbar level, leading to the paralysis or the weakness of quadriceps, which is LMN. But out of the alpha, so the tracks, the overall spinal cord considered as the UMN, upper motor neuron, which is associated with the cortex, cerebellum, basal ganglia, and all the spinal cord above the end. So L2, that is known as the UMN, upper motor neuron. Now what happened? If my LMN means lower motor, I told you again, the teacher level, which is the LMN. If in the school, in the whole body, if teacher is not functioning properly, students are paralyzed person. Like, they are like, they are very weak, they don't know the stuff. So if teachers are not good, students are not getting the proper knowledge. That way, if the spinal cord is not working at the lower level, like cauda equina or the alpha motor neuron or the LMN level, students are weak or paralyzed in a downgrade manner. But whole system is not working. Brain level, that is UMN, it is become the spastic or rigid. So if the patient has the UMN symptoms, where there is the exaggerated tone, spasticity, Babinski reflex, deep tendon reflex is exaggerated versus 11 muscle paralysis, flaccidity, absent deep tendon reflexes, and no Babinski. Which is the difference between UMN versus LMN? Any question? Vinita, all correct?
Yes, ma'am.
Okay. Now, below that, so I told you spinal cord is end. This all is known as chorda equina, and the level where this is happen, it is known as cornus medullaris. So this is a pinpoint level. Below that, there is a chorda equina. Chorda equina, it is purely lower motor neuron. They have no control, like they are not included in the upper motor neuron, versus conus medullaris, which is the pinpoint, half UMN, half LMN. So you get the mixed picture of UMN plus LMN. That is a one story which is inside the spinal cord. But spinal cord is not like stagnant. It has a roots, franchises. Like we have a T Morton. So T Morton has a lot of franchises. Same way, spinal cord in the body, it has the roots. So now digging little bit this stuff, so you understand what is the radiculopathy, which is MSK portion. And spinal cord is your neurological portion. So focus here a little bit, which is not in the book. So what I told you, spinal cord is a continuation process that communicate with the brain. That hello, how are you? I'm taking right now lectures in front of you. I'm aware, my eyes on the screen. I know that what are my students. So this is the my awareness. But what I need to speak, that is my knowledge is appear through the my vocabulary. But on the same time, I do some action. I will explain you. So that action is a principle. My brain gives signal to my spinal cord at each level, and then I will perform. On the same time, I'm sitting in front of you with maintaining my balance. I may go here and there, which is my dynamic balance also. But I am stagnant, stability. I'm not moving, I'm not walking and talking. So mobility is not there right now with me, but I can maintain. I'm not like this, I'm not balancing disturb. So this all coordinated works. Clear now? So this is the brain communication with my spinal cord. But how my spinal cord communicate with my muscles? So now at each level, right and left, nerve roots emerge. Now this is nerve roots. It's not spinal cord. Spinal cord is the thin line center. But after that, nerve roots emerge, which is going out through the vertebrae. And now these nerve roots, I can say for example, C4 nerve roots is associated with the myotome and dermatome. What is myotome? What is dermatome? Myotome, muscles supplied by a single nerve root. Now, imagine this is my hand, C6, middle finger C7, and the little finger C8. We know this stuff. So this is my dermatome. But what about my index finger? What about my ring finger? So the index finger has a overlapping, just a minute. Index finger has a overlapping C6 as well as the C7. Ring finger overlapping C7 and C8. So if I want to identify that what exact level, I can touch pinpoint and I can get the idea Okay, C6 is affected because index finger is normal or they can get little bit sensation, but thumb there is no sensation. So means particularly C6. Same way, patient has the absent sensation here, but here and here hypo is there. So C7, particularly C7. Any question here? Dermatome, myotome, and nerve roots. Khadija, trying to understand?
Yes, ma'am. The last part that you just said that, for example, C5, C6, sorry, that goes into the thumb and the index finger. Yes. So now we're talking about myotome here. We know that there is dermatome C5, C6, C7, whatever, but now we're talking about the myotome. So one part goes into the thumb, one part goes into the index finger.
Myotome is different. Myotome is muscles supplied
Yes.
by the single nerve root.
Yes.
So myotome is the different, and for okay everyone, dermatome, myotome, you are going with the Kirschner. And neurological level, spinal cord, you are going with the Sullivan. I will explain the difference. So that's why I'm just digging with the slow motion. Dermatome and myotome. So here I'm gonna say that C6 is the dermatome. Dermatome means, see, this is the stuff I want to tell. That this is my spinal cord, yellow one. If spinal cord is damaged, cut, then we are not working about the dermatome and myotomal level. We are working with the neurological level. But if my nerve root is injured, for example, C6, then my C5 is also normal, C7 is also normal, T1 is normal, T2 normal, everything is normal. Only C6 radiculopathy. Versus if I am saying C6 spinal cord injury level means C6, after that everything is gone, including L2, L3, L4, everything. You understand what I mean? Where is Runda?
Yes, ma'am.
Understood?
Yes, yes.
So this is the difference between radiculopathy as well as the spinal cord injury. Now, what I want to convey is dermatome, radiculopathy, and neurological level. We will discuss neurological level, but right now radiculopathy, which is the MSK portion, it is associated with the given nerve roots. And how, as a physiotherapist, I am identify that my patient has this problem via analysis of dermatome, myotome, but here there is no spasticity. There is no DTR exaggerated. It is the dermatomal and myotomal problem, which is the lower motor neuron because it is the spine nerve roots and then going with the body. And only one level or maybe C6 and C7, that particular level, particular muscles supplied by that level is affected. So I'm going to say C6. So the muscles supplied by the C6, which is C6, who is Vinitha? C6 myotome.
Ma'am, you want me to tell C6 myotome? But C6 myotome is wrist
Is it
extensors.
Okay.
Can you hear me,
So,
ma'am?
yeah, I can hear you. Correct.
Yeah, wrist,
But at
wrist
little bit,
extends,
along with there are also other stuff.
elbow flexion and wrist
Correct.
extension.
So myotome and dermatome, which is MSK portion, remember it is like your Garba style in the Gujarati style, or C4, which is your elbow stroke, C5, which is your chicken wings, C6 is your elbow flexion and the wrist extension, C7 is your elbow extension, and C8 finger abduction. That way you have to remember that is your myotome. Myotome supplied by the muscle, supplied by the particular nerve root. Bhavin, clear?
Yes, ma'am.
For the lower limb, myotom and the neurological level is almost same. So for the lower limb, L2, hip flexion, L3, knee extension, L4, ankle dorsiflexion, L5, great toe extension. These are the basic 4 level. If patient has a hip flexion, means L2 level is normal, hip flexion grade 3. Or if patient has a hip flexor weakness, L2 level is affected. Now it is applicable to dermatomyotome as well as spinal cord. There is no change. But for the upper limb, C4, C5, C6, C7 and C8. That way you have to differentiate dermatome, myotome, nerve root, radiculopathy. It is all spine, vertebral problem, facet joint entrapment, disc herniation. These are the terminology. But when we are working with the neuro, it is your spinal cord compression. So spinal cord compression means as a whole. Now imagine my brain, spinal cord also gives a signal and then muscles are working. But now this route is out of the track. Route is not available. From Canada to India, flights are stopped now. So in that scenario, brain is working their way, spinal cord is working their way. I'm just giving an example. So there is no communication between the brain and spinal cord. Individual. Now spinal cord as a teacher, they are at the lower level. They don't know how to, teacher are good in the teaching. They are good with giving the muscle contraction. But they don't know that which students we have to give proper education. So that way, because they don't have a higher control. So management is required to give the proper. For example, in our house, father control is more important. Mother control is their way there and the children. You can consider that way. So correlate the spinal cord. So when the total connection cut out of the track, they have no idea what to do. Crisis about the the money and all this stuff. So crisis about the coordination, crisis about the tone, crisis about the balance, everything pop up. And patient has the problems in terms of balance, in terms of mobility, in terms of independency, in terms of coordination. So any questions so far? So now let's jump little bit with the neurological level. So neurological level means what? When the whole section of the spinal cord is cut. So in that portion, first, when patient has injury, you cannot identify what is the neurological level because they have a spinal shock. That what happened. Okay. After that, the body is acquainted and whatever level is normal, they appear to function. Below that, they are not getting signals and they are appear as paralyzed. So neurological level must be identified once spinal shock is resolved. For example, you met with some accident or I'm sorry, but saying that if you, in your family someone has a death. So first thing is your brain never accept that that person is no more. So that is your shock. But after that you realize that okay, he is gone, you cry, you are like feeling of that person, everything taper down after a certain period and then you are stable. Think for yourself. Same way, when the spinal cord is totally cut, immediately everything is in the shock. What happened, they don't know. So they shut down the system. So everything is flaccid. Gradually, spinal shock is diminished and appropriate level is pop up. And as a therapist, it is your duty to identify that neurological level. Now, neurological level. Anyone has an idea? Question goes to Bala.
Ma'am, the level where the injury has happened,
Hmm. This is
we
what
can
called
find
neurological level.
it with the dermatome and myotome.
Wrong. That's what I am saying. Dermatomyotome is now root.
Yes.
Key muscles and key sensory point. That is your
Uh,
neurological level.
yes.
For
For
me,
instance, in above T5 gets affected means I'm sorry.
that's okay. Fine.
Yeah.
Urvi, do you want to say?
Yes, ma'am, about neurological level. It's the inferior level of regular sensation or something.
Almost correct. But very like superficial.
Oh, okay.
Okay.
Ma'am, the
Now
caudal level where motor and sensory functions are intact.
intact. Okay.
Intact, yes.
So the level, okay, look at me. So this is my cervical cord is somewhere here. Now my head is flexed. So when my head is flexed and I got the injury, so what happened? This spinal cord, it is a movable structures. When you do the bending, it goes up. When you do the extension, it goes down. So now if I had a fall with the bend of the neck, so maybe I got injury at C4. God, God saves me. So C4 vertebral level, I got injured in case. But at that time, my neck is flex, and maybe my spinal cord is bending. When I'm bending, my spinal cord is little bit up. So C4's level in the spinal cord is up, and at the C4 vertebra, my spinal cord level is C6, and that getting the cut. You understand what I'm saying? Something, this is a rope, this is a spinal cord. So imagine this is the level of injury, for example. But when I am doing the bending, so I got injury here. So at present, normal structure, this is my neck, vertebra, and this is the cord. But when I do the bending of the neck, this cord goes forward, and now at this level, little bit different portion of the spinal cord is up here. And if I got the injury here, means this level, like the level where I got the injury, that level and the vertebra is C4. Both are injured parallelly. Everyone get the idea or still difficult? Anirudh,
Ma'am, I was going to ask if you could repeat this again.
repeat. Okay.
Yes, please.
So who is Sanish? Sorry? I couldn't hear your voice.
I'm sorry, it's Nishu. My name
Yeah,
is
Nishu, go ahead.
So basically, ma'am, then in let's say, for example, in the flexion injury, since spinal cord went off C4, let's say C6 got injured, so that means C4 is still intact, right?
Kind of.
Okay.
So, see, this is my spinal cord. Okay, when I'm doing the bending, if you can see, when I'm doing the bending, the my spinal cord goes up, and the lower portion, for example, Anirudh, let me draw here. So this is my neck area or the patient's neck area, and this is the spinal cord where here the C5 vertebra is there, and C5 level of the spinal cord is also there. That portion clear?
Yes, ma'am.
Now bending of the neck. So now flexion of the neck. So the associated C5 spinal cord level goes up, but the vertebra is remains stagnant there because I am bending with my C1, C2, noding thing, C1, C2.
Yes, ma'am.
So if I am nodding C1, C2 and then bend, so spinal cord is little bit up.
Mm-hmm.
So imagine
Yes.
my injury happened at the C5 vertebral level, but my spinal cord is injured at the C7 level. You got my point now?
Now I got it, ma'am. Yes.
Everyone clear?
Yeah.
So this is your neurological, like this is, that is actually the picture. And now as a therapist, you need to get the idea that what is the neurological level in my patient. So I'm just explaining that When patient has an injury, the vertebral level is injured, which is different, and what is the spinal cord level of injury is different, and as a healthcare worker, you need to identify that level which is known as neurological level. Clear, Krishna, Mahima? Now, spinal cord, neurological level, but now what is neurological level? So neurological level means as a healthcare worker, I need to identify caudal most. Caudal most means below that there is no appropriate stuff. So what is the lowest level where I can get motor plus sensory on right and left normal? And what is the definition of the normal? Grade 3 in the MMT scale. Again, I will explain that neurological level, which is the caudal most area of the spinal cord, where therapists get normal, motor and sensory, right and left, same, both the sides same grade. This is known as neurological level. And for the identification of the neurological level, therapist wait until the spinal shock is disappear. After that, you will assess key motor points, key sensory points, and then identify your neurological level through the ASIA scale. This is the figure. So this is different than your radiculopathy. This is different than your dermatome. This is different than your myotome, which is your MSK portion. This is your neurological portion. Here you are working with the spinal cord. So you need to work with your key motor, and beauty is only we have a 10 muscles. 5 upper extremity, 5 lower extremity, that's it. If the area where we have no key muscles, we are relying on key sensory points. Now, what are the motor level? So I want Mahima explain me myotome. What is myotome? C4?
C4, I think it is scapular elevation.
Then C5?
C5, shoulder abduction.
Then C6?
C6 is elbow flexion plus wrist extension.
Very good. C7?
C7 is elbow extension and wrist flexion.
Correct. So this is your myotome level, myotome particular. In the Asia scale, in the neurological level, there is no C4. So now have a look. Sorry guys. Actually, it's a blur image. It is in the Sullivan. C5, only we have a one group is elbow flexors. It's not biceps. Remember, I will again work on that. It is not biceps, it is elbow flexors. It is not one muscle. C6, only wrist extensors. So in the spinal cord level, by flexors C5 and then C6. Where in myotome, it is combined with the C6. C7, both the same, elbow extensors. C8, finger flexion, and T1, finger abduction. That point clear? Now, for the upper limb only, so spinal cord injury and the cervical level. What I need to do, I need to do the MMT from the C1 to C4. I don't have a key motor muscles or the motor points. So that level is identified via sensory examination. And then if everything is normal, then I'm moving with the C5 key muscles. My patient, if they shows elbow flexors grade 3 on the right and left grade 3, both the side is there, then I can say that motor level is C5. Then I'm going with the C6. C6, here there are flicker contraction and here is a normal, but I cannot consider C6 as a motor level because for the motor level, it must both the side is the grade 3 normal. Clear now? So this is my motor level C5. Now let's move on the sensory examination. Now sensory examination, we have a sensory points, only points. It's not like whole area. Dermatome, if you see in the Maggie, there are a area is there, right? What I say C6 is this and this. C7 is middle finger and this 3 finger is a C7. Dermatome is the area supplied by the single nerve root. But in the spinal cord injury, it is a pinpoint level. So only you touch this point. If patient has a sensation, good. If they have no sensation, 0. That way. Key sensory point. 0 means absent. It's a blur, but it is in your Sullivan, it is there. 1 is impaired, 2 is normal and not testable. The area where they have no key muscles, we can identify that motor level via sensory point examination only. You have to use two techniques, light touch, and pin prick. So you have to assess two sensations and both the sensations are normal. Normal means grade 2. Then we can consider sensory level. Any question here, Granth? All good? Is there or no? Hitansi, all clear?
Yes, ma'am.
Correct. So basically, key sensory, we have a two sensation we have to check, light touch and pin prick at particularly sensory points. Clear now? Now what are the key sensory points? So see, have a look here. They mentioned already, this is C2. Suboccipital area, if you touch C2, C3 anterior neck area, C4 over the clavicular area, so this is your C4, C3 middle clavicle, C4, then C5 lateral elbow, C6 pinpoint, C7 pinpoint, C8 pinpoint. T1 middle elbow and T2 axilla. So only pinpoint, you're gonna use assess the light touch and pin prick. Both the sensations are normal. You can write it down in the scale, normal, and then you're gonna calculate that score. Pin prick and light touch, that portion clear. And the area where you have no key muscles, you can rely on your sensory examination and you can consider this is normal. So now that way for cervical, I'm going to discuss right now. So motor level and sensory level. So motor level on the right side, C5 has a 3, C6 has a right side, C5 right side 3, C5 left side 3, C6 right side 1, C6 left side 3, C7 that is paralyzed, nothing for the motor. For the sensory, C5 normal right and left, C6 normal right and left, C7 normal right and left, C8 onwards there is no sensation. So what is the sensory level only here? Question goes to Nishu.
This is sensory level is preserved at all the levels. So this is the
Sorry?
and sensory level is preserved at all the levels. So this is incomplete spinal cord injury.
So what is your sensory level in this given scenario? C5, C6 or C7? You cannot choose all the level. Only one level you can choose as a sensory.
C5.
Wrong answer. It is the uppermost. You have to select the caudalmost.
Oh yeah, sorry. Yes,
Clear now?
yes, yes.
That is known as caudalmost, the lowest level where you can get both the sensation normal in both the side.
But C5 also like sensory to both are like normal, no?
No, both C5. Your answer is correct as a neurological level. My question is sensory level.
Okay, sensory, yes. Sensory is
Clear?
yes.
Okay. So in the given scenario, what I told that, just a minute. C5, both the side is grade 3. C6, right 1, left 3. On the other side, sensory, C5 normal, both the side, C6 normal, both the side, and C7 normal, both the side, C8 no sensation. So here in the given scenario, my patient has a motor level which is C5 and sensory level is lowest C7. And identification of the neurological level. So neurological level where both motor and sensory are normal, which is C5. Any question now? Aisha, Nasreen, all clear?
Yes, ma'am.
Hmm?
Yes, ma'am. Yes, clear.
Clear? Perfect. If any question, right away ask me. Because this is very important when you are going with the condition, when you are going with the answers, your understanding of neurological level. So if I am saying, okay, I'm asking different way. If I am saying my patient has, question goes to Aisha now, okay? My patient neurological level is C7. Means what? Triceps is paralyzed.
It yes, no. If C7, then tricep is intact.
So here triceps is normal. So whatever neurological level they are giving, that level as a normal motor, and below that there is nothing. Clear
Yes.
now?
Yes.
Shabnam is here. Sorry. So now let's go with a little bit in detail about this thing. Complete or incomplete and zone of partial preservation. According to you, what is complete? Question goes to Hina.
Yes, ma'am.
Complete level of injury means what?
There is a no motor and sensory.
Below the neurological level.
Yeah.
That is known as a complete. And what is incomplete?
There is a no motor, but somehow sensory below the neurological level.
Just a bit.
Like you have S2 and S3.
So this is the grading, ASIA scale. Complete means patient has no motor and no sensory function, is preserved in the sacral segment S4, S5. And you get the level, neurological level. Complete means there is no motor, no sensory, even in the sacral segment. And If I am saying my patient has a C7 complete injury, means up to C7 everything is normal, below that there is nothing. But sensory incomplete means below the neurological level, sensory is normal, there is no motor. Motor incomplete below the neurological level, some keel muscle has the less than 3 grade. Motor incomplete below the neurological level, half of the key muscles has a grade 3 but inappropriate, right and left. And normal means our body, which has a, there is no neurological level, everything is normal. So that is our Asia scale. So you get the question, Mr. 38-year-old Mr. Roy having a spinal cord injury C8 complete, Asia scale A, means C8 is normal, below that nothing. Clear now? And now the work is zone of partial preservation. So zone of partial preservation means what? So here there is a complete injury, but just a minute. Complete injury, incomplete injury, and the zone of partial injury. So complete means there is a no sensory, no motor in the lower segment with no sacral sparing. Sacral sparing means sensory function as S4, S5 is a patient's ability to feel the deep anal sensation. Incomplete injury means motor and sensory is there below the neurological level but inappropriate order. And if individual has motor and sensory function below the neurological level but does not have a sacral sparing, then the intact motor area below the neurological level is known as zone of partial preservation. Means what? That I told C7, but below the C7 patient has a T1, patient has so motor and sensory both are there, but patient does not have anything, and then directly L3 patient has. Sacral sparing is also not there, but T1 and L3 they are preserved. So that is known as zone of partial preservation. So let's discuss this thing one more time. The neurological level of injury. The neurological level is defined the most caudal level of the spinal cord with normal motor and sensory on both the side left and right. Motor level decided by testing the strength of 10 key muscles on the right and left. Key muscle we can assess by using MMT. And if they have at least grade 3, which is considered as a normal in MMT. Single muscle represent one myotome, which is generalization. But here we are using the group of the muscles. The most muscles are innervated by more than one segmental nerve root. Usually two nerve root innervate each muscles. For example, extensor carpi radialis longus, ECRL, receives innervation from C6 and C7 spinal nerve root. It's not a level. What we are saying, wrist extensors, which is the C6. But if you are going with a dermatomal assessment, particularly separate muscles. Sensory level is determined by assessing patient's sensitivity of light touch and pinprick on left and right side body at the key dermatomes, means key sensory points. Scoring of sensation is absent, impaired, and normal. The sensory level, which is the most caudal level with normal light touch, normal pinprick sensation, where the area or the level where myotomes or the key muscles are not clinically testable, the motor level is defined by the intact sensory level like T9. So T9 only we have a sensory points. We don't have a key muscles. The key muscles is defined have an intact innervation if the MMT is 3 and the roster key muscles exhibit 5 strength. Clear now? Now let's Any question here? First of all, neurological level identification. See, this is the table 20.5 where they are more apply the motor level and key muscles. So muscles. Here what we are saying wrist extensors, elbow flexors, but what are their muscles and available movement that also you have to mug up. So C1, C2, C3, C4, the all the muscles, the available movement is talking, mastication, sipping, blowing, and scapular elevation. Remember, trapezius and the SCM supplied by the spinal accessory nerve, which is the cranial nerve. So that one, even the spinal cord is damaged, but the cranial nerve is intact. That's why patient has the shoulder shrug and the SCM. C5, elbow flexors. So if patient has the C5 level, elbow flexors are intact, means biceps, brachialis, brachioradialis, and the above C4 and C1. So deltoids, infraspinatus, rhomboids, supinators, and the available movement is elbow flexion, elbow supination, shoulder external rotation, shoulder flexion and abduction up to 90 degrees. So you have to be memorize this portion from the table. C6, wrist extensors. But what are the extensors? Extensor carpi radialis, infraspinatus, latissimus dorsi, pectoralis, pronator with the C6, supinator with C5, teres minor and serratus anterior. And C6 movement is, so C5 up to 90 degrees, C6 all the way up. C5 external rotation, C6 internal rotation and adduction, scapular adduction, protractors, upward rotation, forearm pronation, and wrist extensors. But they don't have a finger flexion. C7 only elbow extensors, but along with that elbow extension, wrist flexion, and finger extension. C8 purely finger flexion. So that is I divided as the cervical and the lumbar in my PPT, but you are getting as a whole in table 20.5. Any question in terms of neurological level? Complete. All good? No question? Nasreen?
Revision.
Revision. It takes time.
Yeah.
It takes time.
Ma'am, can you repeat that partial? I couldn't
Zone of
understand.
partial preservation.
Yes, ma'am.
See, when neurological level is decided, if it is complete, there is no sacral sparing.
Okay.
See where it is. Complete means there is no sacral sparing, there is no anal sensation.
Okay.
Sacral sparing means sensory function at S4, S5 dermatome is preserved after spinal shock, which is the symptoms. When I can say that there is a resolution of the spinal shock when patient has a cremasteric reflexes appear or anal contraction, which is the sacral sparing.
Okay.
Okay, that is known as a sacral sparing. Complete injury, you might get sacral sparing, sacral segment anal sensation, or the contraction is there. But in the zone of partial preservation, even though patient doesn't have sacral sparing, but particular level below the neurological level, they don't have a sacral sparing, means at the end, see, this is the spinal cord, at the end, CS3, S4, it is not there. Sacral sparing is not there. But below the neurological level, like C7 is the neurological level, below the neurological level, some areas are intact in the motor and sensory. For example, T1 and L3, I'm giving an example. So you get the knee extensor contraction, you get the finger abduction contraction, but after that there is nothing. Sacral segment is also not there. L2 is also not there. T2, T9 not there. So this is known as a partial preservation. Clear now?
Okay, ma'am.
Any question? Which is complete injury. Okay, now let's go little bit detail from the spinal nerves. So spinal nerves, what I told you, that are 31 pair of the spinal nerves emerge from the nerve root, that is a facet joint. And they are capable to compress at particular level and only one side. So for example, patient has left C7 radiculopathy. Means what? Right is normal, C6 is normal, C8 is normal, T1 is normal, only C7 radiculopathy is there. Clear now? Difference between radiculopathy and neurological level. Now we are going with the track. So spinal cord, they are working with the tracks. Descending tracks means the higher control giving signal to the lower level. So that is name begins with the cortex and name end with the spinal. So corticospinal, lateral and anterior corticospinal tract, which gives voluntary movement of axial muscles and significant about the voluntary movements. So elbow flexion, all the movements, voluntary movements. Vestibulospinal, position of the head and neck. So right now I'm gonna talking, I'm gonna see something, I'm gonna see the wall. So here and there, it's the movement is there and I can get the orient. Same way vestibulospinal, they are responsible for the position of the head, posture, balance. Reticulospinal. Reticular means, when my sleep is really bad, but when I had a sleep complete, I have no idea what is going on. But I am awake, I'm getting the idea, okay, who is this, where I am. So that is my reticular system. So reticulospinal tract giving the idea about the automatic movements, giving the idea about the awareness, and rubrospinal movement of the limb. So these are the all the descending tracts which is associated with the movement, posture, balance, and coordination. So descending, which is already carries the information from the brain giving to the spinal cord, versus ascending. Ascending is they give signal to the spinal brain cortex. So here names start with the spine and with the area of the brain. Spinothalamic. So here this tracks anterior spinothalamic tract, which gives and carries the sensation of touch and pressure to the thalamus. Lateral spinothalamic tract carries the sensation of pain and temperature. Fasciculus gracialis and cuneatus, which is associated with the fine touch, 2-point discrimination, conscious proprioception, stereognosis, weight discrimination, vibration. Spinocerebellar, subconscious proprioception. Somebody give me like, hi Mamta, and back, the back tap, I will maintain my posture. Subconscious proprioception. So if I'm going to see ascending and descending track, so this is the cross section of the spinal cord. Red one is the descending one. So lateral and anterior spinothalamic, anterior corticospinal tract, which convey the information to the alpha motor neuron, and alpha motor neuron gives signal to the muscles. And ascending, so ascending, this posterior portion carries the information about the proprioception, 2-point discrimination. The lateral segment, this one is the spine, the ascending tracks, right? So they give the spinocerebellar. And anterior aspect, there is a spinothalamic, anterior spinothalamic. So anterior spinothalamic and lateral spinothalamic. So anterior is touch and pressure, lateral is pain and temperature. So this lateral, anterior. Anterior is touch and pressure. This is the pain and temperature. they carry the signal here. Only names, more than enough, their function, more than enough, how they are going with the different, where, what level they do the cross section. Okay. Now, this what I say that complete injury. Complete injury means everything is cut. So complete injury means below that there is nothing. But incomplete injury means only the portion of the spinal cord is injured, like the hemisection or the anterior portion or the central portion or the posterior portion. So according to that, you get the cord syndrome, which is considered as incomplete. Now see what I told, that corticospinal tract, laterally anterior corticospinal tract, which is the descending tract, and ascending one is the anterior spinothalamic, lateral spinothalamic, rubrospinal, that are the ascending tract. Cuneatus and gracialis, that are ascending tract. Now question, everyone is sleepy? Let's have a break, 2 minutes. Then we are working with the incomplete. Okay. Let's everyone is here.
Yes, ma'am.
Okay, go ahead. So now the cord syndrome. What I told you that complete injury. Complete injury means completely ascending track, descending track, middle portion of the spinal cord, everything is gone. And you have to identify the level, like neurological level. But anterior cord syndrome, central cord, you cannot identify the neurological level. How come? Because few thing is there preserved, few thing is not there. So incomplete injury like anterior cord, central cord, Brown secured, you cannot identify the neurological level. Keep in your mind. Neurological level is for the complete injury and motor and sensory incomplete. That portion neurological level. But some syndromes where you are going with the features wise. So anterior cord syndrome, let's go with this first. Mechanism of injury is patient has a cervical flexion injury, damage to the anterior portion, because when I have a flexion, my anterior portion is compressed and getting injury. So the anterior portion of the spinal cord is compressed. And symptoms, because anterior, so this is my spinal cord, and in that one, anterior portion is damaged. So when anterior portion is damaged, leading to the anterior corticospinal tract as well as the portion, because anterior cord means whole anterior portion, some lateral is there. So the corticospinal tract is damaged, leading to the motor function loss, spasticity. Anterior portion has the anterior spinothalamic tract which carries the signal to the brain in terms of pain and temperature, which is lost. But the lateral spinothalamic tract, which is on the lateral portion, so that one is preserved. Now, proprioception, vibration, light touch, which is carried by the fasciculus gracialis and cuneatus, which is on the posterior aspect, which is preserved. So the anteriorly motor function loss, pain and temperature sensation is lost below the lesion. But proprioception, light touch, vibratory sensations are preserved because that is carried out by the dorsal column. Like this. So here, sorry, this one. Now the posterior cord. Posterior cord means it is not given, but just for your idea, only the fasciculus cuneatus and gracialis, which is carry the proprioception and 2-point discrimination. That sensation is lost versus normal muscles, normal pain and temperature that is preserved. Central cord. Central cord means center portion of the spinal cord is compressed. It is central cord. So now imagine this is my spinal cord is moving from the skull to the down and the central portion is squeezed only. So in that one, when patient has a hyperextension injury, the central cord is pop up and leading to the damage. Highly cervical spine leading to the central cord syndrome. It is mimic with cervical myelopathy. Myelo means spinal cord injury, cervical myelopathy, compression of the cervical cord. And in that scenario, patient has lower extremity function is preserved, but upper extremity is gone. So patient can walk, but cannot grip. Clear? Because here cervical tracts are affected, sensory impairment is less because central cord is affected. So outside corticospinal tract and the sensation is normal. Recovery to ambulate, patient can walk, and loss of upper extremity function. Brown secured means half is damaged. So here it is some extraordinary features that at the level and below the level, same side and opposite side, that way the features are pop up. Brown secure when patient has a gunshot injury or the knife Saif Ali Khan. He's just as a, like it's not brown secure, but he's about to get because he has a stabbing injury. So in that one, half spinal cord has a high chance to damage. Same level, at the level, loss of all the sensations and the functions, but now below the neurological, not neurological, sorry, below the level of injury, it's not neurological level of injury, same side, paralysis of corticospinal tract is not there, so paralysis of the movement, and patient has a loss of loss of proprioception because it is supplied by this, loss of light touch vibratory sensation, but opposite side because this anterior spinothalamic tract cross below the level, that's why opposite side pain and temperature sensation is lost, but opposite side movement is preserved, opposite side proprioception is preserved. So right leg patient feels the sensation if patient has an injury on the left side, so left side movement is lost, vibratory proprioceptive sensation is lost, versus right side pain and temperature is lost. That way combo pack you will get in the Brown secure syndrome. Have a look with the question. Go ahead. Nikita, what is the answer?
Ma'am, in this question, the answer is 1 because it is same side weakness of position and vibration and the contralateral of pain and temperature, which
So have a look
because
in
of
the
test,
option. So let's go with the 4-1. Sparing of the tracks to the sacral segment with preservation of the anal sensation and active toe flexion, which is not present, not appropriate for the brand secured because here there is a variety, same side, opposite side, and at the level. Loss of upper extremity function with preservation of the lower extremity function, mainly seen in the central cord syndrome. Loss of motor function and pain and temperature sensation with preservation of light touch and position sense below the level of lesion, which is appear in anterior cord syndrome, and ipsilateral weakness and loss of position sense below the level of the lesion and contralateral pain and temperature, Brown secured. So that is your cord syndromes. There is no neurological level, but the level of injury, and below that you get the symptoms.
Ma'am, I have a question, please.
Go ahead, Aisha.
Ma'am, do we need to memorize the pathophysiology or the tracks? Like, okay,
You are a
no need.
physiotherapist dealing with the clinical symptoms.
Okay, right.
You
So
got
we
my,
don't
that's
need.
why, go ahead.
So we okay. So no need to remember at what level the tracks are, like
Crossing,
crossing and all that.
that's why I
Okay,
didn't dig. Because
okay,
that is not clinically you are getting that picture that okay, this level, the level is crossed. It is all pathophysiology. We are not like PC point of view, go with the practical.
okay, perfect.
Because if
Thank
you
you.
are digging yourself here, you cannot dig with the clinical point of view. We have
Okay,
a lot of things. Ethics is also associated. So I'm just working with what is your requirement. What track carries the pain, temperature, touch, vibration, and the movement that are basic requirement that you should know.
okay.
Clear now? So that's why I use a pictures to get the idea. Yes, Nishu.
Ma'am, in central cord syndrome, why is motor loss more in upper extremity than in lower extremity?
Because central cord syndrome is like the cervical area. when the patient has a hyperextension injury and then cut central cord. Now central cord, I also mentioned here, this is from the
Mentioned that cervical spine injury is the more that gets affected. So yes,
no, Nishu, actually I not get the clear voice from your side. But central cord means what? Central cord has the high chances at the cervical level. Why? Because cervical is the most mobile thing versus thoracic and lumbar. That is the one thing. Second thing is hyperextension leading to the narrowing of the spinal canal in the cervical vertebra. So if I'm going little bit in depth, cervical vertebra, if one vertebra over another, leading to the lumen like this. And in this lumen, the spinal cord is passing. Clear?
yes, I'm clear.
Now if I'm doing the extension, see, if I'm doing extension, the center portion is like bent. This is my spinal cord, and if I am doing extension, central cord is bent. You got it here? See. So the central portion is pop up. So at that time, central cord is high chances to damage. And now, center cord contained in the cervical region, cervical areas, figure it out, is central, upper extremities, fibers, and the signals, they are contained in the center portion of the cervical side. And lower extremity is like long fibers because it has to go to the down. That's why they are little bit outskirts. And that's why if the central cord syndrome happen or the compression leading to the involvement of the upper extremity more versus lower extremity.
Clear now.
Clear? And same symptoms you are getting in cervical myelopathy. Any question? Yes, Ina.
Ma'am, you mentioned about the Asia scale, so it's just used in the complete injury and not in the incomplete injury.
No, complete and incomplete both, but not the cord syndrome.
Okay.
You can identify complete and incomplete through the ACS scale. We have incomplete, but it is not a cord where the same one side pain and temperature is gone, other side motor is gone. At that point, you cannot identify the neurological level.
Okay.
Clear now?
Yes.
Neurological level complete means below that there is nothing, but a half side there is completely lost. The right side is lost. Left side patient has everything is normal in brown secure. So you cannot identify the neurological pure level. So where you can say level of injury.
Okay.
Clear?
Yes. Thank you.
You're welcome. Now moving onwards with the cauda equina. Cauda equina actually the ponytail and is purely element. Below the L2, there is a cauda equina. Here element symptoms. Nerve roots below the L2 patient has the flaccidity. It is not UMN. So difference between UMN and LMN is there. So it is not a UMN. Motor weakness, paralysis, sensory loss, saddle anesthesia, flaccid bladder. Now bladder, flaccid and spastic is a different topic. Bowel incontinence, sensory abnormality in the bladder and rectum, and reflexes are areflexia. So this is the spinal cord end, and then the nerve root is there. So this end portion is known as conus and the cauda. Gradual, it is unilateral onset, radicular pain, back pain, asymmetrical, areflexia, and this thing. Conus. Conus means bilateral. It is symmetrical, hyperreflexive because there is a spasticity. Conus medullaris occurs when the distal portion of the spinal cord is damaged, result in mixture of LMN and UMN. Patient may have a spastic bladder. Below the neurological level of the conus, or is conus medullaris syndrome again. That means spasticity below, and at the level there is a flaccidity versus cauda completely LMN, paralyzed. Flaccid paralysis, not the spastic paralysis. So that is your overall idea about the syndromes, neurological level, ascending track, descending track, only the functions and the location of the spinal cord. That is more than enough. Don't dig too much in detail. Spinal nerve root, something I already taught in the spinal lecture of MSK. But here I just explain so you can get the idea. You are not confused that okay, what is radiculopathy, what is radiculopathy and what is neurological level. Radiculopathy means it's emerged, spinal cord is no more. But neurological level, it is actually with the spinal cord. Okay. Now, when you are preparing for your PC point of view, I prefer don't dig yourself with the medical management. We are not doctors to go with the the surgery and all this thing. But what is your role in a team? That is crucial. So you have to work accordingly. Any question, anyone? So good to go. Okay, what? Just a minute now. So we are done for that. I will give you the recordings for this.